Good afternoon and welcome to our neuroscience lecture series. I am Dr. Khaled Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health International. It is my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America, the Caribbean, and everyone joining us today. During this interactive presentation, you will have the ability to ask questions via the Q&A feature located in the bottom of your screen. I will be the moderator of today's lecture. This afternoon, I have the distinct pleasure of introducing Dr. Victor Maciel. His presentation is titled Advancing Colorectal Surgery, the Role of Robotic Technology in Minimally Invasive Care. Dr. Victor Maciel is a general surgeon at Baptist Health. He specializes in colorectal surgery. Dr. Maciel earned his medical degree from Guadalajara University School of Medicine in Mexico. He then completed his general surgery residency Ascension Health St. Vincent Hospital in Indianapolis, earning outstanding performance awards throughout his practice in that particular hospital. Dr. Maciel completed a minimally invasive colorectal surgery fellowship at the University of Texas Houston Methodist Hospital and then an advanced gastrointestinal and minimally invasive surgery fellowship at Jackson South Community Hospital, followed by a colorectal surgery fellowship at Allegheny General Hospital in Pittsburgh. Prior to joining Baptist Health, Dr. Maciel spent 4 years as a practicing general and minimally invasive surgeon for Broward Surgical Specialty in West Palm Beach. He's a member of the American College of Surgeons, the American Society of Colon and Rectal Surgeons, and the Society of American Gastrointestinal and Endoscopic Surgeons, and of course, in the American Society of Metabolic and Bariatric Surgery. Please let's give a warm welcome to Dr. Victor Maciel. Dr. Maciel, what a pleasure meeting you for the first time. Thank you so much for accepting our invitation, and the floor is yours. You may go ahead and present your PowerPoint.
Well, thank you very much for having me. It is a pleasure to be invited to this lecture, and let's get to it. I'm gonna start sharing my screen.
Perfect.
All right. Well, thanks again for having me. Thank you for the presentation, the introduction. I am a general colorectal surgeon at Baptist Health Medical Group, and I last week I was in Mexico visiting my parents, and as we were going through boxes that I had there, I found pictures of myself. I probably was 1 year old, and my parents took me to a fair, and in that fair there was a robot, and my mom took a picture of me looking at the robot, fascinated. I found also a picture of myself in my second birthday, and in my cake, I have a tiny little robot, and I'm just fascinated by that little machine. And of course, I found my old toys that I used to play with, and I had robots all the time. So I realized that I had been obsessed and very intrigued by robotics and technology since a very early age. I was also very drawn to the healthcare, and I found in surgery discipline that could mix the two. So therefore, I started looking into how to mix both of my passions into one discipline. Fortunately, I met Dr. Lujan here in Miami, who invited me to do research with him. He is one of the pioneers in minimal invasive surgery, a great expert in robotics, and we started looking into robotic technology and how that helps patients. So in 2010, I came here to the States and started helping Dr. Lujan with his research. So that's a little bit of a history about me, but let's talk about history for minimal invasive surgery. So surgery has been performed for millennia, right? It was really minimal procedures until the discovery of penicillin in the 1800s. where really the options for surgery were open for us. So the patients were having bigger, more complex procedures without dying or getting septic. From that to the first laparoscopic procedure had to pass about 150 years. The first laparoscopic cystectomy was done in 1987 in France. And it wasn't until 1991 that the first complex procedure was performed. I consider colectomy a complex procedure that now can be done with minimally invasive surgery. So the time frame from the first simple laparoscopic procedure to a more complex one was years. And then fast forward to the 2000s when the FDA approved the Da Vinci surgical system, which is the robot that I use. From the first procedure performed with that machine to the first robotic colectomy, the time frame that passed is only 1 year. And that gives us an idea of how important the shift in or the benefit that robotics gives us to us surgeons. So basically, in my opinion, um, robotic surgery takes a complex procedure and make it easier so more patients can benefit from a minimal invasive approach to their surgeries. So when we talk about the robotic systems compared to laparoscopy, I believe that the main advantages that the robotics platform affords is the visualization. When you're doing laparoscopy, you're only seeing the anatomy in 2D. With robots, you have 3D high definition visualization. Anyone that has done laparoscopic surgery knows that the camera fogs, the cameras are not great. It's sometimes difficult to discern the planes, especially on bloody surgical fields. And robotics really improved on that and makes us see things better and therefore be more careful and more precise. Also, when you're operating with laparoscopic instruments, you're operating with rigid instruments that basically look like gigantic chopsticks. They look like this. They don't have any articulation. It's just like a long, rigid instrument. With robotics, what the Intuitive company did is they designed the robotic instruments to mimic the freedom of the human hand. So all the robotic instruments are wristed and mobile in several degrees of motion. So a complex operation that is done minimal invasive feels more intuitive to the surgeon that is used to do open surgery. Additionally, the robot helps filter the tremor, so you can do very precise suturing, very precise dissection without the normal tremor that all of us humans have. So when I see a patient in my office, I have three ways to help them. Okay. So I imagine that I'm joining a patient in a journey. I need to take him from point A to point B, and I have three options. I have open surgery, laparoscopic surgery, and robotic surgery. So I like to think of open surgery as I am taking the patient on a journey on a bike. All right. A bicycle is very reliable, it will take us to point A to point B, but the journey will not be very comfortable, right? Both of us at the end will be very tired. It's gonna be a bumpy ride, and we may hit, a pothole here and there, and it's gonna be tough, all right? For laparoscopic surgery, I like to think of an improvement from open surgery. This is my analogy is Volkswagen sedan. All right, so very reliable. It's also going to take us from point A to point B, but it has suspension, it has air conditioning. We're both gonna get there. We might get there faster, but it's gonna be a much more comfortable ride. All right, the patient is gonna recover faster. It's gonna feel great. Now, if you really want to have the Ferrari of surgery, I offer them robotic surgery. Robotic surgery is the most advanced way that we have to take the patients in their surgical journey through the end, right? So robotic surgery will be very comfortable for the patient. We will be able to take them through the finishing line, but in a much better, more comfortable, more precise way. All right. So I'm gonna tell at the end a little bit of my journey through open surgery to becoming a robotic surgeon. But as of now, the majority of my complex cases are started robotically. I only reserve open and laparoscopic surgery for certain impossible cases. All right, so we talked a little bit about what my options are and why do I choose minimal invasive surgery now as the main option for my patients. First of all, when you're doing a minimal invasive surgery, either laparoscopic or robotic, you're using smaller incisions, which in turn result in less pain. Therefore, the patients require less narcotics. Very frequently, I send patients without any narcotics at all. This results also in reduced length of stay. If the patient is not hurting, they get up and walk faster. If you're not manipulating and traumatizing tissues, if you're careful with your tissue management, the patients don't develop ileus, they can go home sooner, they can return to work or other normal life activities quicker. And additionally, there's less complication rates, less wound complications. So therefore, the patients can go back to enjoying their lives quicker, and the hospital expenses are decreased. There's a myriad of benefits, immediate benefits, if you utilize minimal invasive surgery for your patients. Additionally, I forgot to mention that the risk of bleeding is diminished as well. All right, so minimal invasive surgery sounds great. What kind of surgeries can be done with laparoscopic or robotic surgery? So, um, anything that I can do with an open operation, I can do with laparoscopic or robotic surgery. However, minimal invasive is better tailored for certain things, especially surgery in the foregut, surgery in the mediastinum, in the thorax, in the pelvis, surgery in obese patients, complex operations that require reconstructions. So if you think about it, foregut surgery is actually easier than open surgery when you're employing a minimal invasive surgery technique. The same goes for pelvic surgery, such as colorectal surgery, gynecologic surgery, urologic surgery. Now, I'm going to focus only on what I do and what my specialty is. So, before I became a colorectal surgeon, which is my primary subspecialty right now, I used to do foregut and bariatrics. Okay. With bariatric surgery, you are required to work on very heavy patients, and sometimes you have to perform complex reconstructions. Laparoscopic surgery is a great way to do these operations, but it's very difficult. Not everyone can do a laparoscopic bypass, laparoscopic duodenal switch. And I believe that robotic surgery has helped many more surgeons perform minimal invasive surgery, and therefore more patients are benefiting from faster recoveries and safer surgeries for this kind of complex procedures. The same goes for hiatal hernias, hiatal myotomies. The robot helps be more precise and the patients recover faster and better. I do employ robotics for simple general surgery procedures such as cholecystectomies, sometimes appendectomies, sometimes small bowel resections, hernias, and I'm gonna talk a little bit about that as the conference keeps going. But in general, the take-home message is robotics is approved for any abdominal procedure that can be otherwise done open. So since I am a colorectal surgeon, I'm going to spend a lot of time talking about my primary subspecialty. All right, so why I think colorectal surgery benefits so much from robotics. So in a lot of my cases, I am working in a confined space, which is pelvis. And working in a pelvis is very difficult because sometimes you're dealing with very limited space, very limited visualization. Sometimes trying to do this operation with my hands is very difficult in narrow pelvis, heavy patients. So minimal invasive surgery has helped me stay in the right plane, prevent damage, do a better total mesorectal excision for cancer cases. Doing a precise mesorectal excision is key in preventing local recurrences. So minimal invasive surgery and specifically robotics has helped me be better. Also, when working in the pelvis, you are working very close to nerves that are important in preserving urinary, sexual, and defecatory function. And the enhanced visualization that the robotic platform allows helps me see the nerves before I cut them. So the same goes for the uterus. I'm going to show a video that shows how easy it is to identify important structures before you damage them. And therefore, there's better outcomes in low rectal cancers. Patients that otherwise would probably get an abdominal perineal resection and losing the sphincters and having a permanent stoma. With the use of robotic surgery, I can prevent that and restore continuity of the gastrointestinal tract. And this is also because the robot helps me suture in a minimal invasive way, but easier. I am a very good laparoscopic surgeon, but laparoscopic suturing is always very difficult. And whoever has had the opportunity to suture with the robot and suture laparoscopically very rarely goes back to suturing laparoscopically because robotics just makes it so much easier. And again, robotics helps me do smaller incisions for my patients and sometimes no extractions because I also do natural orifice extractions for selected patients that otherwise I would not be able to do with laparoscopic techniques. And finally, the risk of complications and conversions is less because I can do more difficult cases if I have better tools, and therefore I don't need to convert and fix problems with open surgery. So when I came here to the United States, I met Dr. Lujan and I joined his research team in 2010. I came here to help him look at his journey um, converting from a purely laparoscopic surgeon to a robotic surgeon. He is a master laparoscopic surgeon. He was doing 100% of his robotic colectomies laparoscopically when he decided to completely convert to robotics. So I was interested in seeing how that conversion was for him. Okay, so we looked retrospectively in all his cases that were not selected cases, that were continuous cases, retrospectively from 2011 to 2008. He made the conversion in 2009. It took him only less than 10 cases to do a hybrid procedure to converting completely to robotics. And at the end, when we put everything together, we discovered that obviously robotic surgery, when he was in his learning curve, took him longer, but the estimated blood loss was similar. The complications were similar. The hospital stay was similar. But we noted an interesting fact that the extraction site was smaller when the anastomosis, the reconstruction was done robotically, because we were able to do this intracorporeally. That means inside the abdomen without having to pull the intestines out of the abdominal cavity to suture. We theorized that this was because when you're suturing intracorporeally, you don't need to dissect and mobilize a lot, um, and therefore less pulling into the tissues resulted in smaller extraction sites. And we're thinking, is this really something that matters clinically or not? Okay. I'm going to answer that question later, but I wanted to, well, I guess let's answer it now. Um, this is an old video of me doing intracorporeal anastomosis when I was doing my clinical fellowship with Dr. Lujan. This is an older video. You can see, but the technique hasn't changed. Here, I'm suturing the two ends of the bowel. The small intestine is being sutured to the right colon or transverse colon. And suturing with robotic techniques is so much easier because, again, the instruments are wristed and very precise. The tip of the instruments measure only millimeters, and they're very intuitive to use and help us perform very good reconstructions. Okay. So after completing the creation of the common channel, the enterotomy is closed with robotic suturing, which I'm showing here. And this is just to highlight how easy and how much it looks like you're suturing with your with open techniques, but just in a much more in a smaller scale. And smaller scales in surgery result in less trauma and better recovery. There have been studies where they measure acute phase reactants and inflammatory molecules and compare the levels with minimal invasive surgery and open surgery. And obviously, the less trauma, the less manipulation of tissue afforded by minimal invasive surgery, the lower the levels are. So there is demonstrable benefits in the short term if you are doing minimal invasive surgery, even for very complex surgery such as colon resections. Okay, so when we wanted to look into our results, we proved that intracorporeal anastomosis has better clinical outcomes, okay? And we were asked by Dr. Umansky to write a book chapter precisely in this topic. So we did a very extensive literature search, and we demonstrated that if you perform intracorporeal anastomosis, you get short-term benefits resulting in lower hernia rates, smaller incisions, shorter hospital stay, uh, quicker return to bowel function, etc. The rest is pretty similar because both of the operations are minimal invasive with exception of the construction of the anastomosis. And this is the benefits are minimal but noticeable, and it is a trend in the entire world. The majority of the surgeons that start um, that convert to robotic surgery very rarely go back to performing extracorporeal anastomosis because we do believe affords we do see the benefits in our patients' recovery every day. Right? So what about left colectomy, low anterior resections, and other or other colorectal operations that we do? Um, I also did another study with Dr. Lujan where I looked at a special subset of patients that in my training I found them to be very challenging, which was the acute diverticular disease complicated with fistulas. All right. These operations or these patients have acute inflammation with chronic fibrosis in the pelvis, and the anatomic planes are blurred. We frequently see chronic abscesses, scar tissue, a lot of adhesions in a confined area. And I wanted to see if robotics actually made a difference. And what I found is that in terms of conversion rate, if you started laparoscopic, your chances of converting to an open operation was about 15%. And after we went over our learning curve with the robot, our conversion rate in these particular cases of colovesical fistulas was zero if we started robotically. So the patients have a better chance of leaving the hospital without a big incision if the surgeon chose to start the operation robotically as compared to laparoscopically. Okay. And I think this translates in other challenging cases, like for example, uh, cancer operations. Over here, I'm doing I believe this was a splenic fracture tumor that is marked with a tattoo that you saw there. I selected this video because I wanted to show you how easy it is for me to identify the ureter that you can see there in the background. With robotic techniques, I can also identify the nerves, the iliacs, the vasculature of the bowel, the tail of the pancreas before I injured them. All right. So my instruments with the robotic platform are very reliable in terms of hemostasis. Over here, I'm transecting the mesentery of the rectosigmoid with minimal blood loss. The staplers that I have are smart staplers that will not fire if there is a lot of tissue or if the staple height is not appropriate. Over here, I'm about to transect the vascular pedicle. So again, I have identified and protected the ureter, which is in the background. And this transection over here is done about 1 centimeter above the takeoff from the aorta. So you have to have complete trust on the instruments that you're using. You see how the takeoff of the artery is there beating. You have to be absolutely confident that your instruments and your precision with the tools that you use is perfect. Uh, Robots have also helped me do a medial to lateral approach to my cancer operations 100% of the times, and I feel very confident that I'm giving them the best oncologic results that I can because these techniques have made me a better surgeon. And again, over here, I'm working very close to vascular structures, big veins that you see there in the bottom that if you're not careful, you can make them bleed, and the bleeding from that vein is disastrous. Um, let's see if I can fast forward a little bit. Another incredible feature of the robot is the ability to identify perfusion with injection of indocyanine green. Everything that turns green has good perfusion. Everything that does not probably lost a little bit of its perfusion. So when I started doing robotics, I thought that I was anastomosing good tissue, but then by using this feature of the robot, I recognized that approximately in 10% of my cases, when I was going over my learning curve, needed to be revised. So if I didn't have this technology, I would probably had 10% more complications than what I had. And here we're testing the anastomosis, which is patent and completely airtight with endoscope, and this marks the end of the procedure. So other things that I love about the robot is that in the video on top, I'm demonstrating how easy it is to identify the ureters with injection of the indocyanine green in ureteral catheters. This is reserved only for very difficult reoperative cases where the ureter is at particular risk of being damaged. So you can identify the ureter by this green, sorry, the green dye help us mark where the ureter is, and therefore you avoid those areas um, and prevent ureteral injuries, which is one of the things that colorectal surgeons worry about the most. On the video in the bottom, I'm showing a just a colostomy reversal, which it is a common reason for referral to colorectal surgeons when you are in a reoperative pelvis. Putting the colon back together may be very difficult, and certain patients will never have their colostomies reversed because the surgeon is afraid of entering a difficult field. Now, with robotic surgeries, we have been able to reverse more of those difficult patients with good outcomes because the technology helps us be more precise and therefore making a complex operation simpler. Okay. I do perform this operation frequently as a referral from other surgeons, acute care surgeons, trauma surgeons that just don't want to deal with this. And the patients are very happy to have them reversed with minimal invasive surgeries, even after big laparotomies. What about rectal cancer? Rectal cancer is one of the things where one of the cases where robotics really has made a difference. The first study, this is a landmark study, the Roller study, that looked into comparing laparoscopic versus robotic techniques in rectal cancer. And this is a multicentric, multi-institutional trial that compared laparoscopic versus robotic. And basically it proved that robotics is not inferior to laparoscopic surgery in terms of rectal cancer resections. Now, subgroup analysis demonstrated a slight benefit in male pelvises and for obese patients. However, it did not reach statistical significance. Now, I can tell you that in my practice, when I have such a patient with a radiated pelvis, male pelvis, and obesity, I do not think twice and I start that case robotically. And with me, apparently the rest of the world is because the trends in rectal cancer surgery are as follows. Robotic surgery for rectal cancer was only 5% of all the cases in 2010 and has steadily increased to become almost 50% of the cases in a decade. I think this is remarkable. And it wouldn't happen if robotic surgery wouldn't afford the surgeon the more precision and basically made a complex operation easier. I think a lot of us are recognizing the benefits, and once we try robotic surgery, we'll never go back. Laparoscopic surgery, in turn, peaked in 2014 and has been consistently declining. And by 2020, the majority of the cases for rectal cancer were performed robotically. And obviously, open surgery is happening less and less and less as more minimal invasive equipment is available for surgeons. So I do believe that robotic assisted surgery is beneficial for the surgeon and the patient, and it will become the gold standard if it's not really, it already is. Another very important uh, another very clear advantage of the robot is with transanal minimal invasive surgery. This is a technique that we perform for selected tumors located within 10 to 15 centimeters from the anal verge that may be cancerous or need resection. And for certain patients that would require proctectomy with all the morbidity that a proctectomy entails. And basically, with a minimal invasive transanal surgery, we are preserving the rectum for certain patients that qualify for this operation. Now, this operation was previously done laparoscopically, and if laparoscopic suturing is difficult in the abdomen, trying to suture laparoscopically inside a patient's rectum is extremely difficult, very, very difficult. Um, and robotics has helped us suture much easier. As you can see in my video, the articulation of the instruments helped me suture as if I was suturing, facial laceration, very, very simple. And again, this is resulting in a lot more preservation of rectum, preservation of function, preservation of sphincters, which for patients uh, does have a big impact in their quality of life. Okay, now let's talk a little bit about general surgery. Okay. I'm just gonna show different cases that I've done in general surgery that highlight the benefits of robotics. In this video, I'm showing a big peristomal hernia. This was a permanent ostomy that could not be reversed, and the patient was having a lot of symptoms from her hernia, causing problems with the appliance, etc. So we offer her a preperitoneal approach of a peristomal hernia. She additionally had a midline incision here. So our plan was to cover the entire midline hernia and the ostomy hernia with a gigantic mesh. Over here, you can see the peristomal defect. I am going to fast forward a little bit to where the hernia is shown. We start with lysis of adhesions at the ostomy, which again is very easily done robotically. This would be very difficult to do laparoscopically just because of the angle. Every time that you're working in the abdominal wall laparoscopically, it is very difficult. Now, here I'm accessing the retrorectus space in the contralateral side of the hernia. And this is something that robotics makes it super easy and much more available to other surgeons. Over here, I'm crossing through the midline to expose the midline hernia, which you can see here. It's very wide. I'm gonna show the measurements in a moment. So over here, you can see the midline defect that I'm pointing at, and this is the peristomal hernia, a few centimeters. But what really demonstrates the benefit of robotics is how you can fix this gigantic hernia in the same time as you can fix a peristomal hernia with a minimal invasive technique. Okay, so here I'm going to be suturing the muscles right next to the ostomy, and next I'm gonna start suturing the abdominal wall hernia. And I think in this video I don't show the mesh, but the mesh measure approximately 20 by 25 centimeters and covers the entire abdominal wall without exposing any foreign material to the abdominal viscera. Okay, the video is available on YouTube if you're interested in seeing the entirety of the video. And here, this is one of the my favorite operations. I'm showing a minimal invasive robotic inguinal hernia repair. On the left, I'm showing how a open incision would look like compared to the three little incisions that I make for this procedure. I chose this operation because it shows anatomy well, not because it was a particularly difficult case. But I want to highlight here how I'm obtaining hemostasis very close to the infamous vein of death that runs in the pelvis and a tributary of the iliacs with precision. Any false movement here can result in massive blood loss. And I believe that having the robotics in my practice helps me be very precise in this dissection. Here, I'm reducing the hernia sac and separating it from the cord structures. Preservation of the core structures is very important as well. I do believe that I'm able to visualize and preserve the structures better when I'm reducing the hernia, as you can see here. And therefore, my patients have less pain, faster recovery, less complications. I very rarely have seromas anymore. Very rarely my patients complain of pain, and that did happen when I was using laparoscopic and open procedures. Over here, I'm pulling the hernia sac down, and over here, I'm identifying the vas deferens that you will see here in the forefront. That white core structure right there is the vas deferens protected. And I'm going to dissect posteriorly. You'll see big nerves and the iliac itself. So you know that you're working in a very in an area where a lot of important structures are separated by millimeters, and you have to be very precise in your dissection. And with this robotic technology, I feel that I'm very precise. My dissections are very hemostatic, and the patients recover fantastic. Over here, you're going to see the nerve, the arterial nerve in a minute, and the iliac right there. That white structure there, you have to protect at all costs. And over there, big purple vein that you have to protect at all times. You see it? Very important, stay away from that. Next, I'm going to show how the mesh is deployed after the entire dissection is completed, and how you can cover the entire myopectoneal orifice, and everything is done in a preperitoneal space. So again, no mesh is all ever in contact with the intraperitoneal viscera. And also mechanically, I do believe that placing the mesh on the interior, on the internal ring provides a much better mechanically sound result, as opposed to put it on top, like on an open repair. Here you can see how well everything is covered. No mesh is ever exposed. And if you block the internal ring, the intra-abdominal pressures will actually be stopped by the mesh, as opposed to trying to place a lid on the external ring. It does make better sense to me. The majority of these patients go home the very same day of the operation with Tylenol and ibuprofen only. They may take it for a day or two, no narcotics at all, very minimal complications. Over here, I'm showing one of the most common cases that I do, which is a cholecystectomy. This is acute and chronic cholecystitis. And I switched from laparoscopic cholecystectomy to trying to do almost all my cases robotically, because I do believe that for an easy gallbladder, um, anyone can do it laparoscopically, but once in a while you go into the operating room thinking that is going to be an easy case, and you find alter anatomy, abnormal, aberrant ducts, or you don't know whether what you're looking is an artery or a biliary duct. And again, the ability of the robot to show to differentiate those tissues with the indocyanine green dye helps me. Here, injecting the dye a few hours before the case gets it mixed with albumin and secreted in the bile. So all the biliary structures light up green, and anything that is not biliary will stay dark. Okay, so over here in the forefront, I see the cystic artery, and in the back, I see the infundibulum. Okay. Again, it's not necessary for all cases, but once in a while, you really do need it. Okay. Um, So it helps us get a critical view of safety most of the times, and then we proceed with the rest of the operation as usual. Okay. This was not a particularly difficult cases, but again, when you do need to be precise for difficult operations, the robot is there to help you, and you are very happy you started robotically. What about massive tumors? Even though you're going to make a big extraction site, I believe that the manipulation of tissues is better, even with robotic surgery, even if you have to open and close for extraction. Here I'm presenting a case of a lady that had a big a spleen mass, as you can see on that CT scan. I initially saw the patient because she had a trauma and the CT scan demonstrated this incidental finding. The patient was on anticoagulation, and I was worried that if that spleen would rupture, she would have massive bleeding and turn into a surgical emergency. So I offered her an splenectomy, and I decided to start the case robotically, even even though the spleen was enlarged. So the only thing that I want to show about this video is um, how big the spleen was. Where it is? Okay, so over here you can see part of the upper pole of the spleen with the really big mass right there in the right lower corner of the screen. You can see the splenic cyst, very, very big. But again, the robotic techniques help me dissect precisely around a structure that may bleed, around important structures such as the pancreas, big vascular structures, the colon, etc. And finally, after the spleen is completely removed, you put it in a big bag and you extract it. Fortunately, the patient had C-section scar that I was able to use for extraction. So the entirety of the procedure was performed with minimal invasive techniques, and the extraction was done using an already present scar. So I don't think that I would have been able to do this laparoscopically. I definitely would have been able to do a laparoscope open, but the results would not have been the same. At the end, the pathology ended up demonstrating a lymphoproliferative disorder. So good, successful story. Okay, so now I've talked about what are the benefits for me and for the patients in terms of minimal invasive surgery. Well, what else does the robot have to offer? Additional consideration is the robot is a great teaching tool. I was fortunate to learn open, robotic, and laparoscopic surgery at the same time. And I believe that I understood certain open operations better after I learned how to do them robotically. Like, for example, the inguinal hernia anatomy just made more sense for me when I mastered the robotic technique. Over here in the little video, I'm demonstrating the training modules that my residents have to do before they get into the teaching console. And basically, it teaches them hand-eye coordination in 3 dimension. And this module that you're seeing there is an anatomically accurate module for inguinal hernia repairs. So the residents have to practice on these modules before touching any of the patients, okay? And here in the picture, this is a demonstration of an old system. It was the first system that was available. And you have a patient cart, the surgeon console, and the resident console. We can share, we can take turns. I can give the resident control of one arm or two or all four arms of the robot. And I have a stop button, so if I see that the resident is doing something I don't like, I can immediately get control. In addition to that, I have pointers where I can teach while what the resident is performing the procedure, correcting the plane or redirecting attention to something important. And teaching open or laparoscopically is difficult, is very different. And I feel that robotics have allowed my residents to get better education. Um, where robot robotics is taking us in the future. So one of the few things that I learned during my training is minimally invasive surgery taken to its basically to the extreme, right? So on the top video, you guys are seeing the transanal extraction of a colonic specimen for diverticular disease. So after the completion of the resection, wound protector is introduced transanally, and it can be pulled out through the rectum, and this allows to prevent any abdominal incisions larger than 8 millimeters. So less risk of hernia, less risk of infection, and better overall outcome. The patients do like this approach better, so less pain. Some patients are very conscious about not having visible scars in their abdomen. So this is a very advanced technique that allows for that outcome if the patient desires to have it. Um, the lower video demonstrates a single platform right colectomy, which the Vinci robot has a platform that utilizes only a 2.5 centimeter um, trocar, and you can introduce several instruments through that, and allows you to do very complex operations. Like as you can see, we're transecting the ileocolic pedicle here. We're doing a medial to lateral dissection for tumor, just as if we were using 4 ports. You can see precise dissection of the duodenum there. And the only thing that needs to be done open is the anastomosis, which I'm going to show in a minute. Um, and I'm going to show the results as well. So here we extract the 2 ends of the bowel. The anastomosis is performed with a Barcelona technique, and this is the final result. So when I saw this, it's like, this is incredible. We did a cancer operation through only one incision, and this is the outcome on like immediately on the table. So a lot of patients will benefit from taking bigger steps towards minimal invasive surgery without sacrificing the quality of the surgery. Okay. Now, the biggest drawback of robotics compared to laparoscopy was the lack of haptic feedback. So when you're touching a structure, when you're stretching tissue, when you're driving your needle driver through tissues laparoscopically, you are feeling the quality of the tissue. You're feeling if you're putting too much tension on a suture. You can feel if a tissue is hard or soft, and that was something that the robot was missing. So that was the biggest criticism we gave to the engineers. So the engineers listened and they went back to their labs and they gave us feedback. Now we have instruments with the robot that can tell me how much tension I'm putting on a suture or on a tissue, helping me be more precise and safer. Additionally, several programs that have availability of the robots 24/7 are doing acute care surgery. Like I personally do perforated gastric ulcers or duodenal ulcers with the robot. I'm doing colorectal perforations with the robot, small bowel obstructions with the robot. One of my partners is doing appendectomies even. And I do try to do the majority of my gallbladders robotically, even if it is the most difficult gallbladder that I've encountered or the simplest. I try to do them robotically. And a lot of people question why I'm doing this. Okay, we understand that robotics take a little longer. Robotics cost more, and they say, Victor, why are you doing gallbladders with the robot if you can be done in the same amount of time, but you will be saving money to the hospital? So when I think about this, I like to think of fighter pilots, every test flight that a fighter pilot takes as a part of their training is very costly, thousands of dollars that cost the taxpayers, right? But when it's time to fight, when things get real, you want that fighter pilot to be prepared and used to fly the Raptor F-22 that you see in the picture. And I feel the same. I feel that, yes, it's more expensive to keep my robotic skills up. But when I find that very difficult gallbladder, very difficult colon, radiated pelvis, I am able to fight that battle and I'm ready. Okay, so in my mind, I don't see every case individually. I see the strengths of the robotic program and what that gives the community back. So yes, it's a big investment, but I think it's totally worth it. All right, so as I said, I am fortunate to have done hundreds of open, hundreds of laparoscopic, and hundreds of robotic surgeries, and I wanted to share what I learned in my journey. I initially started doing complex cases open during my training. That was part of how I was trained. And then during my fellowships, we started doing more and more laparoscopic surgery for complex cases. And as a practicing surgeon, I switched to doing all the complex cases robotically. And I have found also that my conversion to for initially my conversion to laparoscopic from laparoscopic to open was high. Then my conversion to robotic to laparoscopic was high as well. And now I feel that I convert less frequently to either modality. I feel that robotics had made me a better surgeon for complex cases. I feel that I can control bleeding better. I feel that I can prevent bleeding, prevent damage to structures that are important when I have better exposure, when I have better imaging, when I have 3D visualization. Um, so I feel that there's many other surgeons that are following or that have the same experience that I have. Um, I also feel that I'm seeing other communities in Latin America and Mexico in particular that are offering robotics for complex operations, robotic Whipples, robotic hernia repairs, robotic colorectals, that otherwise the patient will not be able to get it because a lot of the surgeons have jumped from open to robotics, skipping laparoscopic altogether. And I believe that this is definitely a result of the robotic technology bridging the experience gap. I also looked at my numbers when I completed my 500 robotic case, and I noted that my complication rate has decreased. My patient satisfaction has increased, and I continue to work towards decreasing my operating times with the robot. So in conclusion, I believe that robotics enhances outcomes in colorectal and general surgery. The patients like it, surgeons like it. It is ideal for anatomically challenging locations such as the pelvis, the thorax, the mediastinum, or recurrent cases where the anatomy is going to be tricky, where there's going to be a lot of scar tissue. And the best part is that it has been proven that the outcomes, at least in terms of oncologic outcomes or safety, are the same. And I believe that robotics has made minimal invasive surgery more widely available so more patients can benefit from that. But that's me saying it, but I wanted to share the experience of one of my patients. Let's see if we can hear the audio. Good morning. We're doing the morning rounds here, and I'm seeing one of my postal patients. We did a segmental colectomy, and I'm gonna ask him some questions. He's gonna answer. Good morning. So I just wanted to know how you're feeling today. He's on the first day after surgery. Any pain?
No pain at all. Amazing.
Have you been walking?
Yes, sir.
Yeah.
I walked last night.
Drinking fluids, any nausea?
Yes, sir. Complete.
Drinking, no nausea?
No nausea,
Very good.
no bad feeling,
Yeah.
no
So-
hurting, no nothing.
What do you think of robotic surgery?
Amazing.
Think it's worth it?
Amazing. Amazing.
All right, very good. Thank you very much. Appreciate your insights.
You got it, Doc.
Bye. So this is just one example, but I wanted to share that the patients do like it. So any questions, I'm open to answering them. And thanks again for allowing me to speak to your audience. Thank you.
Thank you so much, Dr. Maciel. What a brilliant way of putting in context all the advancements in technology that you have been privy to and used throughout your career. It is absolutely outstanding. Obviously, you have joined a battalion of phenomenal surgeons, and we are so proud to have you, especially in our centers of excellence for robotics. And one thing that I must mention on behalf of Baptist is the fact that the Robotics Center has been in existence for quite some time. As a matter of fact, we were one of the very first ones to bring Intuitive to the table to bring Da Vinci in. Therefore, the amount of robots that you have at your disposal, it's simply absolutely magnificent. And the other component, yes, indeed. And the other component important to mention is the fact that we have been able to change from generation to generation as Intuitive developed new technologies and included new technologies either in the trokers or the dexterity of the actual hand that helps you manipulate those tissues that you were showing us. But what I would love to actually highlight a few things that obviously we will take as pearls from your lecture, and it's a fact that nowadays physicians that in the past never thought that these type of cyber type technologies they will be able to actually perform it. Now more and more they're accessible to it. And I love your last statement that students or surgical students now are going and skipping completely the laparoscopic component and going directly into robotics for many incredible reasons that you mentioned. And it is incumbent upon us to also highlight the fact that the complications, the hours, the bleeding, the return to OR, all the crazy stuff that you as surgeons had to put up with, and not counting your physical stamina that needed to be invested in your laparoscopic days. I mean, the switch in the paradigm is absolutely outstanding. So you mentioned that you have done, I'm sure at this point, maybe a little more than 500 robotic surgeries. And what in your mind, what would be that threshold, that number of surgeries that a surgeon should feel confident that he or she can start performing surgeries in a Da Vinci robot?
Okay, so yes, I'm very fortunate to work in one of the pioneers in minimal invasive surgery. Baptist has been a pioneer with laparoscopic surgery, robotics, and others. And we also have incredible volume and the support of the institution, which helps us basically be as good as we are. Now, I want to also mention that Baptist has been an education institution for a very long time. One of the best and probably earliest minimal invasive fellowships was housed here in Baptist. And Dr. Anthony Gonzalez has been a pioneer
Right.
of minimal invasive surgery. He has trained many, many surgeons in minimal invasive surgery. Um, and I want to give props to him, but also I want to say that the institution has commitment to train the best surgeons that we can, and part of it is involving robotics in their curricula. All right. Laparoscopic surgery is never gonna be gone. We will continue to teach our surgeons in laparoscopic surgery, but in practice, a lot of the surgeons basically decide to start robotically the majority of their cases because we believe that is better for the patient. Our curricula will always include laparoscopic surgery because there is some cases that the robot is not available or they may want to practice in a rural area. So we're training our surgeons. We realize of the importance of laparoscopic surgery. We understand that open surgery and laparoscopic surgery have their role, but at least for my elective procedures, I want my patients to have the best if it's available. All right. Now we're narrowing the gap from acute care to elective surgery, and we're offering robotics for also any patient that comes in through the emergency room, either if it's 3 p.m. or 3 in the morning, we offer them the best as well. Um, and I'm sorry, the last part of your
Yeah,
question.
no, I was wondering what would be a good
Oh, yeah.
number for you to
So,
say, I have the dexterity to do it
yeah.
robotically.
So we have a curriculum. Basically, the simulations that I showed, that's only one of the several exercises that I require my residents to complete before I let them sit on the console. And those simulations are basically like video games. They give you a score and they tell you you need to be better with your left hand. You need to be focusing on this or that. And until they print out and show me that they have mastered those skills, I don't let them touch the patients, right? Next, it depends also on if I'm training a resident or if I'm training a fellow. A fellow already comes with a general surgery certificate and they went through 5 years of surgery. So for them, the requirements are different, okay? And it also depends on the type of operation that you're doing. I have trained colorectal surgeons and I've trained general surgeons. So the colorectal surgery threshold is a little higher. You require hundreds of surgery before you can feel confident, especially if you're coming from a purely open environment. Switching to robotics takes a lot longer. But if you are a laparoscopic surgeon, as Dr. Lujan, we discovered that the transition from laparoscopic to robotic takes only 10 cases, right?
Mm.
Um, Different hospitals have different requirements to credential you as a robotic surgeon, but it's usually like 2 or 3 proctor cases and 20 cases that you have to report. And you have to maintain a certain volume in order to maintain your robotic credentials. But every hospital is different.
Indeed, it is, and you did mention obviously we're going to be opening residencies in surgery as well, and
Mhm.
our education center now it's posed to be one of the best ones in South Florida, simply because we will have the training site for surgeons with the advent of the new technologies and bringing the Da Vinci in for training purposes only. So we're in the
Mhm.
process of installing those as well for you guys, but. I would not feel comfortable not leaving you without actually asking about the future of robotics, because you guys continuously challenging and pushing the envelope on technology. And I know that you will hear me when I say, what incredible opportunity would it be to actually bring robotics to even farther in the future by doing it remotely. And I
Yeah.
know that many years ago, Intuitive had an issue because they wanted to implement this, but connectivity was an issue. We didn't have the five type of transmission. How do you see that? Is this going to ever happen to for you to have a Da Vinci's placed somewhere and try to perform not maybe a rectal surgery, but do you
Why
think
not?
this is feasible?
Of course. So, very interestingly, the Da Vinci robot was developed by the Defense Department. It was initially designed to be deployed to the front lines, and that the idea was so the soldier, injured soldier, could have surgery in the field, avoiding the necessity to evacuate them to, another country where a surgeon would be operating. Unfortunately, at that time, the lag from where the surgeon would move the instrument to where the action actually happened in the battlefield was prohibitively long. So if you see bleeding and you take more than 3 seconds to stop the bleeding, then your entire field is blurred, and then that's when you need to open, right? So the technology wasn't available then, and the private sector bought the robot and developed this wonderful technology that we have now. But
Yes.
and at the same time, the satellite technology has improved dramatically, and I know that there has been a couple of instances where a surgeon in France operated in, somewhere else, and it's happened. I don't think it's ready for prime time, but the new robots, we're in the fifth iteration of the robot, the Da Vinci 5
Mhm.
has a lot of processing power that is basically proofing the robot against obsolescence, right? So they're building a robot that will be excellent for decades, and it's continuously updated over
Mhm.
the air. So I'm sure that at some point I will be sitting in the surgeon's lounge in my console, and the robot will be in the operating room. The advantage of that would be that, if somebody in Mexico is doing a rectal cancer and they have problems with anatomy or whatever, and they need a surgeon somewhere else that has tens of thousands of cases under the belt, and they want them to take a look, somebody can log from Baptist and say, hey, listen, what I would do is move the plane a little to the left, or careful there, I wouldn't do this or that. We could do combined surgeries instead of having to have a urologist physically with me. I can call the urologist only to log in the console for 30 minutes and help me, lyse the ureters or something, and then I can continue on with my procedure. I know it's happening, but I don't know when it will become regular practice.
Yes, and of course, now that we have an inclusion of I know that you're going to use it dramatically if you haven't already,
Mhm.
with the new consoles and all that stuff for you to at least be helped in navigating those murky waters where you are working on
Yeah,
that sometimes becomes an abstract for the regular eye. I
right.
want to leave with one clarification. I know that you talked about cost. The Da Vinci, obviously, it is a major investment, but if you put it in context, especially what you demonstrated through your research activities, that obviously the length of stay is decreased, which is an important component not only for the payer, but more importantly for the physician and the patient, more importantly for the patient and the physician. But complications, the bleeding time, and all that stuff. Baptist has been at the forefront in regards to cost.
Hmm.
You probably have heard this before in regards to obviously the billing component. So for us, it is best to actually code it as if it was a laparoscopic and allow the physician to determine through evidence and criteria what suits best that particular condition or diagnosis for the patient without necessarily having to wonder who's going to pay for the cost of the robotic surgery. So that is a wonderful benefit that we have, and we have been very successful throughout the years in billing insurance companies at the same cost for laparoscopic to allow the physicians to practice based on
Best
scientific
medicine.
evidence only.
Right.
So, final thoughts, Dr. Maciel?
So I want to comment also on cost. The numbers that I showed are for robotic colorectal surgery, and we're always looking into improving clinical, but also we're conscious about cost. Only last week I learned that robotic cholecystectomy compared to laparoscopic cholecystectomy, they're equalizing in terms of cost, and the same goes for appendix, right? So
That's right.
we will continue working on improving our techniques and our use of instruments so we can make robotic colorectal surgery as cheap as laparoscopic surgery with the added benefit of the dexterity that it affords. So nothing, I just want to say thank you for listening, and I'm passionate about minimum invasive surgery, technology, and robotics, and I am passionate about offering this to as many patients as possible. And I encourage everybody that is listening to do their best to offer minimally invasive surgery if it can be offered. Is worth it.
Absolutely, Dr. Maciel, and the sky is the limit. Obviously, your peers in cardiology and neurology and bone, as a matter of fact, they're using different modalities and robotics
Mhm.
to perform these very complex surgeries minimally. As a matter of fact, you just brought me to think of Dr. McGinn with the McGinn technique in the cardiothoracic
Mhm.
components were minimally invasive procedure for a cabbage, none out of
Imagine.
everything can be done through a robot. But anyway, we can have you for hours on end because this is a fascinating subject,
It is.
and we wouldn't do that to you as a courtesy. But I wanted to thank you once again for accepting our invitation. Welcome to
Thank
our team. We can wait to go out to different countries and showcase your expertise. On behalf of our entire team, thank you once again. And to all of you for participating and listening to this marvelous lecture by Dr. Maciel. If you have additional questions or you have a patient that you would like to refer or you have a complex case that you would like to discuss with Dr. Maciel, please don't hesitate to send it to us. Our email is bhiwebinars@baptisthealth.net. bhiwebinars@baptisthealth.net. We will make sure to forward your questions, your concerns, or your referral directly to him for him to respond back. We look forward to seeing you at our next general surgery lecture series, which is scheduled for September 24th, 2025, and we will bring you some more exciting news in robotics and general surgery. For now, thank you once again. Have a phenomenal evening. Dr. Maciel, you're fantastic. Thank you
Thank you very
once
much.
again.
Have a good night. Bye bye.
Thank you.